Dear colleagues, it's a pleasure to welcome you today for this new session of ESOU Online. It will be dedicated entirely to prostate cancer for this first video of 2022. I'm surrounded by top experts in the field, and I will present the faculty. I have asked Carme Mir from Valencia in Spain to be there. She's ESOU board member. I have asked Arnout Albers to come from Rotterdam. Thank you very much. And Noel Clark from Manchester. Thank you for being there. I think it's time to move on to your clinical case presentation and to have an interactive discussion around a metastatic patient. So Arnout, please go on.
Thank you, Morgan. So this case will be on de novo metastatic hormone-sensitive prostate cancer, and I have no potential conflicts of interest. So our subject of the case is Mr. X. He is 74 years old. He has no relevant medical history besides hypertension, and he has a performance score of 0. He is fit, he has no relatives within his family with prostate cancer, and he's referred by his GP due to mild lower urinary tract symptoms, despite use of an alpha blocker. During the workup for the lower urinary tract symptoms, a digital rectal examination is performed where a prostate nodule is palpated on the left side with suspicions of seminal vesicle invasion. A TRUS is performed where a hypoechoic lesion is seen in the peripheral zone where the nodule was palpated, and he has a PSA of 26. So we decided on performing a transperineal prostate biopsy, and a grade group 5 prostate cancer was detected in all biopsy cores with cribriform growth, extraprostatic extension, and perineural invasion. And there was a maximum core involvement of 90%. So we decided on performing a PSMA PET-CT, and here you can see images of the CT scan that was performed along with the PSMA scan. And on the CT4X, we actually detected 3 pulmonary nodules in the right middle lobe, and these nodules, they were smaller than 1 centimeter. But as you can see on the PSMA scan, 2 out of 3 nodules, they showed PSMA uptake, and therefore there was a suspicion of pulmonary metastases. On the PSMA scan, we also saw that the palpated nodule was highly active within the prostate. There was a hotspot, but there were no lymph node metastases and no bone metastases. So we have an atypical presentation of de novo metastatic hormone-sensitive prostate cancer. That is, if you agree with the fact that these pulmonary lesions are suspicious for metastases. There are no lymph node or bone metastases, and there's a relatively low PSA. And this raises the question, should we trust the specificity of the PSMA scan, or should we perhaps perform a lung biopsy? Noel, maybe you can comment on this.
Thanks, Arno. I mean, this is a really fascinating case, and for anyone of you who are involved in regular multidisciplinary discussions about patients, this is the real world. So there are 2 aspects to this, Arno. I think looking at the cancer side and looking at the comorbidity side. You look at his scan, that's his CT scan. He's a big heart. He has some stents in already. He has a history of hypertension, and his lungs don't look brilliant. On the prostate cancer side, he has clearly a high-risk prostate cancer. Heavy involvement, high grade, PSA somewhat lower than we might expect, and that's not untypical for really high-grade prostate cancer. So putting all that together, further investigations. Well, he has 2 indeterminate nodules on the CT scan, which probably too small to biopsy, I would say. And this may be one indication for doing a PSMA PET scan, because clearly, and in this circumstance, we can't really tell whether it's a metastatic prostate cancer. It's an unusual presentation. I'll come back to that in a minute. And it may actually help us to stratify the risk profile for him. Now, having said that, he's a very unusual case again in that he's got primary pulmonary metastases without any evidence of disease elsewhere. Now, in the STAMPEDE trial, a large volume trial, what we found was that only 4% of the patients presented with de novo visceral metastases. 2% were in the liver, 2% in the lung. So it's hard to be definitive about comments because using charted criteria, they're automatically classified as high volume. But what we know is that the pulmonary metastases respond better than the hepatic metastases. So it leaves us with a few hanging questions as to what to do, which is why it's so important to discuss cases like this, because they don't quite fit the general model which is accepted.
Arnout, just one question. Do you have, I would say, wide access to the PSMA PET-CT in your practice?
Yeah.
And did you use it because of the presentation of the case, or would you use it in any high-risk patient for the, I would say, pre-treatment workup?
Actually, we do. If there's a high-risk patient, a localized high-risk patient, we do the initial staging with the PSMA scan. Okay. If it's very obvious that we're going to find metastases, then we use conventional imaging for the staging.
Okay. So what did you do finally?
Although the fact that these lesions were very small and it's probably hard to biopsy them, we did perform a biopsy because it had huge impact on the treatment decision. And actually we were able to perform a good biopsy, that's a good sampling, and we found that these lesions were in fact pulmonary metastases. So in conclusion, we have a T3B, N0, M1C, visually metastasized, high-risk prostate cancer, grade group 5, with a PSA of 26. And well, you've already pointed it out. There are 2 of 3 small visceral metastases, but we've seen them on PSMA imaging, not conventional imaging. So the charted criteria might not be really relevant, but the question is this high volume metastatic disease, although there seems to be a low burden, but then again, it might not even be that relevant. What do you think, Carmen?
It's a little bit confusing, I guess. Probably, definitely, it's a high risk, and high volume would be like if you consider that as allele less than 3, then it wouldn't be. However, the other thing that caught my attention is as you mentioned, the low PSA. It will be also a sign of some indifferentiated features in the pathology. So that's something that also increases the chances of having something else that you don't see. So that's probably...
Which criteria makes sense finally in the discussion? Because from the literature and the guidelines, we have this stratification, high risk, high volume. I think that the Gleason score here is extremely important. And thereafter, the location of the metastasis. Is it a question of size when you think about it, or just the location when defined by the guidelines? And on top of that, the stratification was based on conventional imaging. Is that right? So I think we have to consider this patient as with a very aggressive disease, high risk of, I don't know, evolution, and for sure the stratification has to be made in that direction. But I think the stratification from the guidelines was not relying on molecular imaging. Am I right?
Yeah, I fully agree. And what you've just said is that is already enough. But the point of size doesn't really matter in this case. Could you comment on that, Noel? Would it have been different if these metastases would have been 3 centimeters instead of 1?
Well, I think the first thing to say is that the disease burden is very important, and I'll come to that in my talk in a sec. But in this sense, the question of high or low volume relates to whether he gets systemic treatment or whether he gets treatment to the primary as well. What we have shown in relation to novel hormone agents is that the high volume, low volume thing doesn't matter. We've published on that from Stampede. And equally, in relation to the use of docetaxel, we published in Annals of Oncology in 2019, looking at high volume, low volume, and again, it didn't make any difference. If you gave the treatment, you got the benefit. And interestingly, a somewhat greater benefit with docetaxel in the low volume than the high volume. So, in a sense, I think this man has defined himself as a high-risk prostate cancer, and if he's fit enough, we would give him maximal treatment. I think that will be our approach.
I agree, yeah. Yeah, that was actually the following question. What would that maximal treatment then be?
Well, I think any of those, on your question 3, I think we were considering for ADT plus novel hormone therapy, or ADT plus docetaxel. I think putting it all together, that's looking at the patient in general with his cardiovascular history, his stents, his big heart, his hypertension. I think we give him docetaxel rather than the novel hormone treatment, for the simple reason that both of those agents, abiraterone and enzalutamide, will send his blood pressure up.
But one message that we can send to the audience today is that in 2022, in high-risk de novo metastatic patients, there is no room for androgen deprivation alone anymore.
Yeah.
So I think option 2 or option 3 should be discussed, but not anymore ADT alone.
It's a very good point you make. So we should go for combination therapy either way. And Carmen, which combination treatment would you then choose?
I have to say that I agree with him with now, because of the point I raised of the indifferentiated tumors also. That is telling you that the PSA is something off there.
Yeah.
So probably would benefit mostly from the big shot at the beginning.
Yeah. So actually, Mr. X, he received the big shot, and with good biochemical response to the docetaxel and ADT, at least up to now, with short follow-up after finishing the chemotherapy. And he had, luckily, had relatively mild side effects of the combination treatment. So that's it for this case.
Perfect. I think it's time for us to go to the conclusion. I hope you had the opportunity to learn a lot from this video session. You can keep exploring the Euro-Onco platform of the EAU if you want to learn even more on these topics: prostate cancer, kidney cancer, and bladder cancer. Thank you very much.